Thanks, Mike. Yes. So as you've heard us speak many times before, we're looking at these seroepidemiology studies that are occurring globally. We are looking at a number of ways. First of which, we're looking at the publications that are coming out. These are peer-reviewed publications, preprints, government reports. And to date, there's more than 150 published results from such studies that Mike has just referred to. These are done various ways using various methodologies. Some are looking at populations, some are looking at stored clinical samples from people who have shown up at hospitals, some are from blood donors, and other studies are done in specific types of populations, among health workers, for example, in specific areas where there was high transmission in slums or in some cities and towns where there was really intense outbreaks. And the results indicate across all of these 150 studies that, as Mike has said, that the vast majority are below 10%, with the exception of some high incidence areas that are above 20, 25%, and some even higher. And so the point is that these studies continue to tell us that the vast majority of the world's population remains susceptible. The way in which we're trying to get a more standardized approach to look at studies and be able to pool these results and combine these results, if you will, is through what we call the Unity studies. And this is a series of 6 protocols that WHO has developed with many, many partners. And in fact, over the last 11 years, because this work began with influenza, because we knew the importance of really trying to understand the extent of infection as measured through these seroepidemiology studies, and the need to standardize this approach, use the same approach across multiple countries so that we can better compare what is happening in one country and another. And so WHO, with our partners, has developed 6 protocol templates for different types of populations. And we're working with more than 50 countries right now to implement these studies, where we are providing technical support on the adaptation of the protocol for the local context. We're providing support and working with the countries who are running these studies themselves to carry them out. And many of these are underway. With the use of a standardized protocol, what we can do when these results are finished, and with the permission of the principal investigators of those, is to be able to compare those and pool those. And this will help us get a good global estimate of what is happening in different populations. You also mentioned the infection fatality ratio. So in addition to this, there are a number of statistical groups, mathematical modeling groups that are looking at the infection fatality ratio, which is the number of deaths over the number of, divided by the number of estimated infections. And there are several papers that have come out that are looking at this. Several of these analyses have used published or preprint seroepidemiologic study results, and they all converge around a point estimate of around 0.6%. Now, that may not sound like a lot, but that is a lot higher than influenza. And the infection fatality ratio increases dramatically with age. So we can provide you with these papers. These papers are published, but there is a big increase in the infection fatality ratio by age. But overall, these converge around the 0.6%.
Thank you. I would like now to invite Bloomberg reporter for the next question, Tim Loh from Bloomberg. Can you hear me, Tim?
Yes, and can you hear me?
Yes, very well. Go ahead, please.
All right, thank you. Yeah, so my question has to do with the recent upsurge in Europe right now. Even in countries like Spain, where the current wave of infections is hitting especially hard, hospitalizations due to the virus are still far lower than they were at the peak of the first wave. I'm just looking for an update on your current thinking as to why this is, and what risk factors might cause this trend to worsen in the coming weeks or months.
Thank you, Tim. Dr. Ryan?
I'll start. Maria will likely add. Well, clearly, as we've seen in all cases of rising incidence so far in this pandemic, that the incidence of hospitalization and deaths lags behind the incidence of cases themselves. And it takes a number of weeks, usually, for those numbers to feed through into the system. But we also recognize that within that, that lag has been over a longer period of time. and it may reflect a shift in the age distribution of cases, or at least of tested cases, with more disease in younger age groups who don't tend to be hospitalized or don't tend to have fatal outcomes. That's certainly it's certainly a factor. But what we are beginning to see worryingly in places like France, like the UK, Ireland, and other countries, is hospitalization rates increasing, ICU occupancy rising. And it's really important that health systems are able to cope with what will be an increasing number of cases in hospital and ICUs over the coming weeks. The question remains as to how many of those daily incident cases convert into hospitalizations and then into very seriously ill patients. And we don't know that. We don't know that for sure. If this trend continues, yes, it could be down to the age base. In terms of people going into ICU or even being hospitalized, again, Maria may speak to this, but we've learned a lot about how to recognize early symptoms of the disease, how to ensure the patients who are vulnerable are better protected, and those that are vulnerable get access to early treatment. I think a lot of this is making sure that those people most likely to fare badly are in a clinical pathway that gets them into intensive care or supported care much more quickly. We also, back in March and April, people on hospital trolleys, great difficulties in triaging patients, patients who probably needed immediate care not getting immediate care. And therefore, the streamlining and efficiency of the system is very, very important. That efficiency drops as the system comes under pressure. And it's a great testament to the emergency, particularly people working in emergency rooms in the front end of our systems have really improved the way in which we streamline the clinical pathways in the hospital to ensure that the sickest patients, or those most likely to become sicker, are getting access to care quickly. We then add in the advent of therapeutics like dexamethasone and the use of high flow oxygen, oxygen concentrators, so many other things that have come on stream. So I think overall clinical care is improving, which won't reduce hospitalization rate per se, but certainly will reduce death rates. So a number of factors in that. It may also be, and this is something that remains to be explored, whether or not the very fact that people have been more socially distanced, the very fact that people are taking more care with hygiene, whether or not people are being exposed to a lower infectious dose. And that is something that's still very, very speculative, something that will be explored and is being explored as we speak. But the reality is that we may not be perfectly effective at reducing transmission between people, but there is a link between the infectious dose, the amount of virus you're exposed to, and the severity of your illness or your likelihood to become sick. Again, a lot of work going on in that. And I believe in the end it will turn out to be multifactorial. There'll have been many reasons. But I think we need to be really careful right now not to make an assumption that the current disconnect between the rising number of cases and deaths, that could reconnect very, very badly and very catastrophically unless we're very, very careful.
Thanks, Mike. I mean, I think you described it perfectly, but as you said, it's a combination of factors that we're seeing this happening across Europe, and in fact, a number of countries where we're seeing a lower mortality rate compared to the beginning of this pandemic. And part of it is due to surveillance, because we are able to test more. We are able to expand our surveillance beyond just severe patients, beyond just individuals who show up at healthcare. And this is a hallmark of outbreaks and pandemics. In the beginning, you tend to focus on those severe patients because that is what your system can cope with. And so as surveillance expands, we are able to test more, we are able to do contact tracing. We tend to find more individuals who are on the more mild end of the spectrum. So that's one. Second, through these second peaks that we are seeing in a number of countries, there is an age shift in the average age of cases that we are detecting. And part of that is because as societies are opening up, individuals are coming away from those stay-at-home measures, they're going back to work, there's a lot of socializing that is happening. And unfortunately, in some of those situations, the virus really, really likes this type of setting and can spread. And we have seen quite a few outbreaks in a number of countries across entertainment type settings, across religious settings, across sporting events. And that will drive the age down. And we know that younger individuals tend to have less underlying conditions, and they don't develop as much severe disease as someone who is older. But also, we are getting better at preventing outbreaks happening in vulnerable populations. The long-term living facilities, for example, in some countries were incredibly devastating in the beginning and unfortunately are still happening in some countries. But if we could prevent the virus from entering a long-term living facility, for example, we could prevent amplification, we could prevent severe disease and death. But the other side of this coin is that we are getting much better at dealing with patients. Clinicians, nurses, frontline workers have experience with COVID-19 now. They're better trained, they are better experienced, and we know, and they know from the hard work that they have dealt with to save lives. So earlier testing means earlier access to clinical care. It means checking that oxygen level in that individual quicker. It means providing oxygen quicker when needed. It means providing ventilatory support if necessary, providing dexamethasone for people who are severe and who are critical. And all of that saves lives. So we're getting much better at actually dealing with patients and treating patients and caring for them, which are leading to more positive outcomes. But the one thing we worry about, and I know we've said this many times, one of the things that we worry about, it's not just numbers of cases, it's not just hospitalizations and deaths, it's about all of the long-term impacts that we are starting to see in individuals who have even had a mild infection, a mild disease. We are only now starting to really learn of the long-term impacts on the heart, on the brain, on the lungs, on mental health, on people's ability to recover from COVID infection. And so not only do we need to work very hard at reducing mortality, and we are seeing the benefits of that, we still need to reduce the numbers of infections that we are seeing. And again, we come back to all of the tools that are in place to be able to do this. We can do it all. We can do this all together because we are all in this together. And it's about individual measures that we take to protect ourselves and having the enabled environment for us to take those to protect ourselves and our loved ones.
Thank you. I would like now to invite a reporter from The Independent. No, I think we will come back to Borzo from The Independent later on, if he's still online. I would like now to invite Stephanie from Reuters. Stephanie, can you hear me?
Yes, thank you for taking our question. I wondered whether, as you probably know, Australia researchers today said in a study that was published earlier today that the SARS-CoV-2 virus can survive on banknotes and glass and stainless steel for up to 28 days, which is, of course, quite a bit longer than the flu virus. So what can WHO say about the transmissibility from such surfaces, please, over such long periods of time? And do you have any, increased concerns or new advice following this study that was published today? Thank you.
Thank you, Stephanie. I would like to invite Dr. Van Kerkhove to take this question. Dr. Van Kerkhove, you have the floor.
Thanks, Fidel. Thanks, Stephanie, for this question. Yes, we're aware of the study that was published. This was an experimental study that was looking at the SARS-CoV-2 virus. It looked at samples that had very high viral loads. There are other studies that have been done under experimental conditions, and of course, we look at those studies to look at our advice and look at how we make recommendations for disinfectants. And what the study found, it was done under experimental conditions, so not real-world conditions. It was done in the dark. Which means it didn't have any UV light of what you would see under normal real-world type situations. And it found that the virus could remain viable for 28 days at 20 degrees Celsius and 24 hours at 40 degrees Celsius. And it looked at different types of surfaces like glass and stainless steel and paper and polymer banknotes. And so we use this information to look at our disinfectants. The good news is that this virus can be disinfected with disinfectants, with chlorine, with different types of very, very quick quickly. And we know that fomites or touching of contaminated surface is one of the ways this virus can transmit. And so what we worry about is if someone is infected and they release the virus and it falls onto a surface, if it isn't disinfected and someone touches that surface, and if they don't wash their hands or use an alcohol-based rub, if they touch their eyes or their nose or their mouth, they can infect themselves that way. So we continue to recommend these basics. We continue to recommend that there's environmental cleaning that is happening in areas where there's known patients, of course, in hospitals and in homes where people are being cared for, but also making sure that we disinfect surfaces regularly. And again, there's good news that disinfectants like bleach work very well at removing the virus. And they're very highly effective of killing this virus. So the measures remain in place. Hand hygiene, carry your alcohol-based rub, make sure that you use it because that will clean your hands and remove the virus from your hands before you can infect yourself.
Just on that, you know, the very basis of hand hygiene, and I'll go back to the old soap and water argument as well. Soap and water is probably one of the most effective public health interventions that's ever been invented because it does everything from getting rid of all kinds of bacteria, all kinds of viruses on your hands, and prevents the spread of any number of diseases from cholera to coronaviruses. So I think having access to soap and water, having access to hand sanitizer, and coming back to those basic messages that we've been speaking about for months, since the very beginning, about hand hygiene and not to forget hand hygiene. And I've seen this myself and personally witnessed it. And I'm very, very pleased to see the adherence to masks and to physical distancing. And then I've witnessed many times people have access to hand hygiene stations going in and out of shops or public transport, and they don't tend to use it because they've made an association that in some way this disease is only spread through droplets or only spread through another means. And in fact, this disease can be spread through contamination of surfaces, however long those surfaces are contaminated for. So it's very, very important that we continue. And again, DG has spoken about this many times. Do it all, and that includes hand hygiene. That includes washing your hands regularly as you can. Not so easy for many people in the world who don't have access even to soap and water to be able to do that. And that is a huge injustice in the world, not only for the case of coronavirus, but for so many other diseases. So I would just say to everybody, hand hygiene is a major part of coronavirus control. This study only reinforces that. We'll see, as Maria says, in the long term what the implications of this and other studies are. But the message is wash your hands often with soap and water, or use desanitizer or sanitizer when you can.
Thank you very much. I would like now to invite Sophie from SABC, South Africa Broadcasting Company. Sophie, can you hear me?
Yes, I can hear you. My question is directed to Dr. Ryan and Dr. Tedros. We have a situation where most countries are currently going to elections. For example, on the continent, you have Ivory Coast, you have Tanzania in 2 weeks' time. You also have the United States of America. And you look at what leaders are doing in terms of their rallies and the campaigns. You have these large numbers. Are you not worried that this will lead to cluster outbreak?
Elections do many things. They're an essential part of our lives, and they're absolutely central to how many societies live, survive, and thrive. They're very important parts of the cycle of life. However, they do tend to bring people together. We've seen many examples over the last 9 months where elections have actually been held very safely and with appropriate measures, and have been straightforward enough to manage and implement. It takes effort. We've worked very closely in the past in the same way we've done for all types of mass gatherings, and we've worked on a risk management approach You cannot reduce the risk to zero, but what you can do is identify and manage those risks, especially where in-person voting is the choice of the country. We don't specify to any country what the proper choice is for the type of election they need to run. That is based on their own risk assessment. But we do offer them advice on how to reduce those risks if in-person elections are the way forward. And in fact, we're working right now on finalizing specific guidance for countries who choose in-person elections, learning from the last 8-9 months as to what has worked in those circumstances, and we'll be issuing that guidance in the coming days. It's a very important question. But like any form of gathering, any form of social process at society level, it is possible to manage them and reduce risk to an absolute minimum if everybody participates and if everybody adheres to what is an agreed method and agreed practice. The problem very often is when those practices are ignored, and that's essentially something that can't be legislated for. But it is possible to hold safe elections if the proper measures are put in place.
Thank you, Dr. Ryan. I would like now to invite Simon Ateba, Africa News Today, to ask the next question. Simon, can you hear me?
Yes, I can hear you. Thank you for taking my question. This is Simon Ateba from Today News Africa in Washington, D.C. I know it's really hard for WHO to talk about specific members, especially the US and especially President Trump, and especially 22 days to an election. But on Thursday last week, 11 days ago, he tested positive for coronavirus, and he's gone back on the campaign trail. I was wondering, first, how long is, according to WHO guideline, how long does the virus stay in the system? When does he know there is no more a risk to other people, especially because he has not done a second test that's proven that he's tested negative? And I was also wondering if what's the best way to go back on the campaign trail after testing positive for coronavirus? Thank you.
Simon, that's a lot of questions, and we're certainly not the personal physicians to anyone in the world, and would not like to make a comment on specific individuals. What we can say is that the US Public Health Services have very clear criteria in place for what represents the release of an individual from what might be isolation due to being infected. And the criteria in the US, Maria may outline them, are very clear. From WHO's perspective, we allow both testing and duration of number of days since the onset of symptoms. Both approaches are used by WHO or offered to our member states as mechanisms. I believe, Maria, it's 10 days from the onset of symptoms and plus 3 days from the onset of the last, or the cessation of the last symptoms. And again, all countries have adapted that according to their national protocols, and therefore we wouldn't comment on whether any specific individual meets the requirements of their national protocol. Maria?
Thanks. Yes. So I can tell you, yes, exactly what Mike has said. For symptomatic individuals, it's 10 days from the time of symptom onset plus the 3 days of symptom resolution, meaning no fever, no respiratory symptoms. We also have criteria for asymptomatic individuals. But what we do is we work with countries all over the world. We work with labs all over the world to look at when people test positive using PCR testing, but also looking at virus isolation from those individuals. And there are a handful of studies that have been underway. We've outlined our understanding of the science in a scientific brief on this, which is on our website. And we are continuing to work with labs who are following patients and individuals over time. And so this is a body of work that is very important for us. We work with our counterparts in the US as well.
Thank you so much. I would like now to invite Bayram Altouk from Anadolu News Agency for the next question. Bayram, can you hear me?
Yes, I can hear you. Thank you, Fadela, for taking my question, and good evening to everyone. I so far worked on a good news from WHO about the COVID-19 vaccine. From WHO perspective, where do we stand with the vaccine development? As number of countries says they are on the cusp of having successful vaccine like China, Russia, USA, UK, and today Turkey. So when will we get a safe and effective vaccine at the earliest? What is your latest update on this? Do you have any good news for us today? Thank you.
Thank you, Bayram. I would like to invite Dr. Swaminathan to answer this question.
Yes, thank you for that question. And we've, of course, continued to track the development of vaccines, and it's really very encouraging to see the progress in the clinical trials happening all around the world. As you know, we have about 40 vaccine candidates now in some stage of clinical trials. 10 of them are in the phase 3 trials, which are the late stage clinical trials, which will tell us about both the efficacy and the safety. So the best that we could make a guess or predict, looking at when a trial started and when it is likely to have enough data to submit to the regulators, is the earliest is starting from December of 2020 into the early part of 2021. We expect a number of clinical trials to start providing data for regulators to look at. And this is going to be a lot of data for regulators and also the WHO. Dr. Simao is here, she may want to add, but we also put out a call for expressions of interest from vaccine developers to submit whatever data they have to us, and so have a rolling submission and update us. But unless we see results from phase 3 trials, so as I said, the majority of the ones which are currently in phase 3 trials will be reporting in the early part of 2021 and beyond. It will continue because many others are going to enter into phase 3 over the next few months. So the good thing is we'll have a number of different vaccine trial results that we will be looking at over a period of the next, I think, 6 to 12 months. And then both regulatory agencies and the WHO will have to make decisions on either emergency use authorization or on regular licensing of the vaccines, depending on the data set that they're able to provide. So I think in the first quarter of 2021 is when we are going to see most of the data coming in.
Thank you, Dr. Swaminathan. I think Dr. Simao would like to add some information.
Yes, thank you, Fadela, and thank you for the question. I think there are other issues that will come into play as well. You know, Dr. Swaminathan referred to the regulators part. Once you finalize a phase 3 trial, this vaccine will need to be licensed. If it proves positive, both safe on the safety side and the efficacy side, this vaccine will have to be licensed in the country where it's being experimented, where the trial took place. And we also have the manufacturing capacity. It will need to be available to be used at country level. So there are many steps that need to be taken after it's the phase 3 trial actually ends. WHO is working very closely with the national regulatory authorities, and like Dr. Swaminathan referred to, we issued an expression of interest for the emergency use listing of a vaccine, and we are accepting any producer, any candidate vaccine that's in phase 2B or phase 3. And we expect this will help to move the process faster as we get the dossiers and we start to analyze not only the efficacy and safety, but we work at the same time with the good manufacturing capacity at each of these vaccine producers, right? So that when the vaccine is finally concluded, the trials, we do have a clear vision of the quality assurance of the product that will come to the market. So I think we will be ready when we are ready. But we are getting there. Thank you.
Thank you, Dr. Simao. I would like now to invite Gabriela Sotomayor from El Proceso to ask the next question. Gabriela, are you online?
Yes. Hola, ¿qué tal? Thank you very much for taking my question. I would like to know about the forecast in Mexico. The first wave is not over yet. The cases are still on the rise. Few tests are done. There are more than 80,000 deaths, but it's possible that there are 3 times more deaths. So Mexico is one of those 10 countries that Dr. Tedros just mentioned. So I would like to know what recommendations do you have? And there is also another serious problem because about 1,000 children with cancer have died due to the lack of treatment, a problem that began to appear in public hospitals before the pandemic. So that is the situation. I would like to know what is your recommendation and your forecast for the country. Thank you.
Hi, thanks. Yeah, the situation in Mexico obviously remains difficult. Until October the 10th, there were over 814,000 cases and over 83,600 deaths from COVID. Again, I think putting it in context, I think nearly half of all the confirmed cases have come from Mexico City and the state of Mexico, Nuevo León, Guanajuato, and Sonora. So in that sense, there's been a big impact in certain areas. About a quarter of the patients reported to us have required hospitalizations, and there's been a preponderance of males over females, about 52% to 48%, but not such a great preponderance. Again, many people, like we've seen all over the world, have had underlying conditions, including hypertension, diabetes, obesity, were the main associated conditions there. And, you know, Mexico has been running this traffic light system, 3-level traffic light system, and interestingly, many other countries have adopted similar traffic light systems in the last number of months. Mexico was one of the first countries in the Americas to introduce that traffic light system, and we would support Mexico in continuing to do that. Health personnel have been very much affected in Mexico, and again, predominantly 60% reported in females, which probably represents the fact that health workers in Mexico are predominantly female themselves. 48% of the cases in nurses, about a quarter of the cases in doctors, and another quarter in other health professionals in Mexico. Clearly, protecting those health workers is very important, and we have, our PAHO office have obviously continued to recommend to Mexico to continue the training, protection, provision of equipment to frontline health workers in Mexico. Again, the same issues arise in terms of a shift of disease into younger populations. There have been issues in the past on the testing strategy and the amount of testing done. I'd also like to commend Mexico. It's been very careful to try. It's had a large bump in cases over the weekend, just before the weekend, because it's actually changed a lot of its definition of cases, not to reduce the number of cases, but to actually capture more cases, particularly those who weren't tested. So Mexico now considers cases who are epidemiologically associated with the confirmed case to be cases, and the same with deaths, which actually puts Mexico in a situation where it will tend to report more cases than elsewhere, and it is to be commended for its transparency on that. So I would say yes, no more than many other countries in North, Central, and South America. No country is out of the woods. Mexico continues to be in difficulty, and it is very tragic to hear your reporting on cancer patients, and we've seen this impact around the world on oncology services around the world, outpatient services, and others for essential care. In many ways, and I think the DG has said this many times before, COVID, to an extent, has caused some of these problems, but it's also revealed huge inequities in the system. As you said, many of these issues may have been present before. So Mexico, no more than every country in the world, has serious inequities in the way healthcare is delivered and the way healthcare is paid for. And it is tragic to hear in any country that children would die unnecessarily from treatable cancers.
Thank you, Dr. Ryan. We are up to the hour now. I would like to invite Dr. Tedros for final comments. Over to you, Dr. Tedros.
Yeah, thank you. No, thank you. Thanks, Fadila, and thanks also to all who have joined today. And see you in our next presser. Thank you.
Thank you, Dr. Tedros. Just reminding journalists that we will be sending the audio file and Dr. Tedros' remarks right after the press conference. The full transcript will be posted on the WHO website tomorrow morning. Sorry for journalists I wasn't able to take questions from. For time constraints, don't hesitate to contact us. Thank you so much and see you soon.